Good afternoon, everybody. Let's thank your organizing committee of the GIS for accepting my case. This is about how to treat practically the no-reflow phenomenon in the setting of the primary PCI. As you see, in these 2 days, we have seen so many cases of the mechanical complication of the intervention. And of course, for the mechanical complication, we have a mechanical treatment. But the no-reflow phenomenon is a physiologic complication of the intervention, and the treatment is more sophisticated than the mechanical complication. Here I go to the case. I have a patient, 36 years, 7 years old man. He just come with the anterior ST elevation MI, with the extensive MI with the ejection fraction of around 35 to 40%. And as usual, we shift the patient to the cath lab after loading the dual antiplatelet therapy and giving a loading dose of the heparin for the primary PCI. Here's the angiogram of the patient. As you see, the right coronary artery is perfectly fine. The circumflex is okay. The ramus is a big artery and has a significant osteal lesion. And at the same time, LAD was totally occluded at the proximal part. If you look at that, the next step is just wiring the LAD and to see how is the flow and then decide what's the next plan for the primary PCI. And after wiring, the flow was not restored. Here we have so many options that we can keep in the mind. There's like a thrombus aspiration, prophylactic 2B3A inhibitor, just go for direct stenting, pre-dilatation and stenting, and finally we need a post-dilatation, thrombolytic therapy, mechanical thrombectomy. All the options are available and on the table, and we should choose. Here, for me, the case was important because for the beginning, this patient is a very young guy, and he already have all the risk factors and the predictors of having a no-reflow phenomenon. First of all, the angiographic thrombus is more than 3 times of the luminal diameters. There's an abrupt cut of the LAD, and the occlusion doesn't have any beak. And there's also accumulated thrombus before the site of the occlusion. At the same time, the luminal diameter of the vessel at the site of the occlusion was around more than 4 millimeters. Patient has extensive ischemia, it's an anterior wall MI, and at the same time, there's absence of preconditioning because the patient is a young guy, there's no collateral, and the chest pain duration is around 1 hour. That means he already have most of the risk factors of having a no-reflow. Then I decided to just do the pre-dilatation with a very undersized balloon, low pressure, and reduce the time of the contact of the balloon with the luminal of the vessel to reduce the chance of the shower thromboembolization. Here I did the pre-dilatation with a balloon 205, and this is the result of the pre-dilatation. The flow was restored, the TIMI flow was good. As you appreciate, the ostium of the ramus has a significant lesion, and the LAD, the proximal part, has a ectatic vessel. And then I decided to go for the direct stenting without any more manipulation of the vessels. And this is the position of the stent based on the distal vessel diameters. The proximal position, I think it was good. It just finally just covered the plaque, and the size of the stent, I think the length and diameter was okay. Then after the stenting, this is the result of the stenting. I was happy with the stenting because the TIMI flow was 3. The patient doesn't have any chest pain. ST elevation was coming down. And by the way, I wasn't happy at the same time because I already know that the proximal part of my stent is well expanded, but fully malapposed, and there is no position. This is a floating stent in the ectatic part of the artery that increase the chance of stent thrombosis and ISR in the future for this young patient. The question was that, should I go for the post-dilatation at the same setting, or should I put the patient for the 2-3 days on the anticoagulation, and after that bring the patient back to the cath lab and going for the post-dilatation? The patient was young, and I don't want to make him the PTSD. Then I decided to do the post-dilatation at the same time, non-aggressive post-dilatation, just to make the stent to become a little bit like a funnel shape, take the anatomy and shape of the vessel. Here I do the post-dilatation with a balloon 405, and the result was after the injection, this is what we see, the totally occluded vessel. There's so many differential diagnoses coming to the mind. One is the acute stent thrombosis, one is the coronary spasm, edge dissection, and the no-reflow. This is the typical case of the no-reflow. The patients dramatically become significantly unstable, the blood pressure drops, is the impending to cardiogenic shock, the heart rate increase, and the patient has ongoing chest pain and ST elevated. And when I see the monitor, as you see on the left side, I see the death of the angel is coming to take the patient and we should act very quickly at these situations. There are different options here. We should go for the mechanical support, or we start to try the treatment of the no-reflow. As you know, we do not have enough data and evidence regarding the treatment of the no-reflow. They're using the many medication like a verapamil, nipride, abciximab, epinephrine, urokinase, streptokinase, nicardipine, the treatment of the no-reflow. But each case should be individualized based on the hemodynamic factor of the patient. The patient was unstable, the patient has a low blood pressure, and for me, in this case, the drug of choice was not the calcium blocker or adenosine that can worsening the hemodynamic of the patients. For me, the best choice was giving epinephrine from the beginning. But the point is that when you want to deliver the drug to the diseased artery, is the better to use the microcatheter or the aspiration catheter to directly inject to the target vessel instead of the wasting the medication to the all vascular territory and other coronary vessels. I started with the epinephrine because this is the first medication and available, feasible, and very easy to use. And the drug of choice was, of course, is a tirofiban because the major mechanism of the no-reflow in this case was the extensive thromboembolization to the distal circulation. After epinephrine given, the patients become tachycardic. By the data, we have that the epinephrine intracoronary injection usually doesn't cause any ventricular arrhythmia. And this is the result after the giving a agrostat, and you can see the TIMI flow was improved. The point is here, and actually the key home message is here, that when you inject the contrast from the microcatheter, you have a better idea and regarding the TIMI frame count. Because when you have an ectatic part at the proximal part of the artery, the turbulence flow in the proximal part doesn't allow this laminar flow in the distal flow will be not impaired. That means the turbulency in the proximal ectatic artery will never allow you have a good opacification of the distal circulation. This is the why even better to take a picture, an injection with a 1 cc of the contrast or 2 cc contrast via the aspiration catheter or the microcatheter to have a better idea about what's happening in your distal circulations. And I started with epinephrine, this result was good. And finally with the agrostat, I just wait for 5 minutes and the patient was improved. Here is the final injection of the patient. And as you see, because the proximal part is ectatic and aneurysmal, still you think maybe the TIMI flow is not good in LAD, but in actually, if you bypass this proximal part with the aspiration catheter, definitely is the flow was much more better in the distal circulation. And I recommend to use that in the patient who suffer from the no-reflow phenomenon. And take-home messages, first in the setting of the primary PCI, no-reflow is a predictable. Clinical and patient hemodynamic is the best guide to select the medication to treat the no-reflow phenomenon, and usually recommended actually using a microcatheter or aspiration catheter for direct intracoronary injection for evaluation of for delivering the medication and also for taking good pictures.
Excellent. Thank you very much.